Okay, everybody, can we get started, please? Okay, welcome everybody to the July public board meeting of the CQC. We have no apologies for absence, which is a good start. I do particularly want to welcome Sue Bevan to this meeting. Sue is the co-vice chair of our Carers Equality Network. As you know, we have a representative of one of our networks at every board meeting. Sue, you're very welcome, and for this board meeting, do feel free to speak at any point that you wish to. Does anybody have any declaration of interest they want to or need to make beyond the normal declarations of interest? Okay, that's fine. Good. So moving on then, we have the minutes of our meeting of the 19th of June, the meeting we had in Bristol. Are they a true and accurate record of everything we discussed? Thank you. So they are approved. We have two items on our action log. The first item we are not quite ready with, so because a response will come to the September meeting now. Yep, thank you. And then item 2 was always scheduled for the October meeting, so hopefully that will happen in October. Was there anything arising that isn't on the action log or isn't anywhere else on the agenda anybody wants to raise? Okay, so let's move straight on then, Ian, to the executive team's report, please.
Thanks, Peter. The report, as you can see, should be taken as read, but I'll step through it in the usual way. There are probably 4 things in relation to performance I'd like to draw people's attention to. I think one is a very pleasing trend from quarter 4 of last year of a number of indicators showing continued improvement. I think where there have been improvements, I think they are a reflection of sustained process improvements rather than simply one-off, if you like, heroic activity on behalf of individual teams. And I think that gives us a lot of confidence for the future. We're demonstrating A, an ability to improve processes, and B, where we have started to do that, what we're seeing is some good work. So I'm cautiously optimistic with the letting recently of a new contract with a continuous improvement provider to support us, that we'll be able to sustain trend over a number of indicators. There is still, of course, work to do in a number of areas, and of course colleagues will be working on that. In terms of one of the particular areas of focus at the moment is sickness absence. Although the headline numbers look pretty good for an organisation of our size and type, we are doing some deep dives into sickness absence to look at whether individuals are being supported to return to work in the way that we would hope, and looking for any particular variations at a team and a directorate level to see if there's any issues. I was also really pleased to see a sustained improvement in the amount of time lost through to IT issues. It's something which we've had a long-standing challenge of over a number of years since we did a fair amount of work over the Christmas period, and subsequently what we've seen is a significant reduction in the amount of time lost through to IT problems. And I think that I need to pay tribute to Mark Sutton and his team, who've been doing a lot of work over a sustained period of time to deliver that. I think there were some challenges from some supplier problems which we enjoyed during June, which we'll probably see a dip in this in June. But I think in general terms, I think the IT infrastructure feels like it is generally now in better shape and is much better understood and much better controlled, which I think is an important area of assurance for the board. And the final thing I just want to draw people's attention to is finances. At the end of May, we were £600,000 overspent. Whilst that's not an enormous number in and of itself, where the executive team are doing a lot of work at the moment on our run rate to make sure that we can bring that number back into line with our budgets, I don't want to get to sort of quarter 3 before we're addressing that. So we're trying to address that good and early in order to bring things back on track. I think there remains this challenge of the capital versus revenue split in our change programme, where increasingly I think we are consuming services in technology services rather than building pieces of technology, and I think that's going to cause us some challenges in coming years around how we split technology and capital. How we split up revenue and capital, rather, particularly in technology, and that's something which again we'll be paying a lot of attention to towards the tail end of this year as we go into next year. So I think that's all I want to say on my part of the report before handing over to Kate. Thanks, Peter.
Thanks.
Okay, so just to update the board on the publication about 2 weeks ago of Smiling Matters, which was a look into oral health in care homes. It was a joint piece of work across primary medical services and adult social care. Very high-level summary of the findings. So dental inspectors joined adult social care inspections, over 100 inspection visits, and the report found that consistently people were not having their oral health needs assessed or met within care homes. The output of the report were a number of actions that the care home sector needs to take around recognising this as a need and making sure the basics are right, such as people have access to toothbrushes, toothpaste, dentures that fit, but also that staff are trained and confident with how to meet oral health needs. There was also a set of asks for training organisations, so Health Education England, Skills for Care and Skills for Health, about ensuring that staff are confident and competent with supporting people's oral health needs. And then there were a set of actions needed around the dental industry. So the report reflected on the challenges for people physically leaving a care home to access dentists, but also it reflected on the fact that it was a challenge getting dentists into care homes to meet these needs. So the report was being really well received. A number of actions are already in train, and our British Dental Association are well engaged and are taking forward at the actions that we need them to as well. Can I just check whether my colleague Rosie wants to add anything to that?
No, nothing to add.
And then just one more up-and-coming publication in adult social care. So in autumn, we will be releasing a report about people's sexual safety when they're in care, in receipt of care services. So we have co-produced this piece of work with survivors of sexual assault and family members, where we've taken a focused look at a number. So the lens of this has been where we've received notifications where a sexual assault has allegedly occurred, and from that we've drawn some themes about what we need to see providers doing to support people around their sexual needs to reduce the risk of it when it goes wrong. So a very sensitive publication that will be available in autumn, that's been well co-produced, but it will have some challenging messages in it, I think, for us as a sector.
Thanks, Kate. Ted, I think to you now, please.
Thank you, Peter. Can I just mention a performance issue, the report timeliness, which, as you know, has been an issue for us in hospitals for a while. The figure for May was 52%, which is down a bit on what it was at its best. But as I said to the board before, a lot of work's gone on to improve this. You'll see on the graph, the tables, that variability of report timeliness has come down. But we've reached a plateau. What we've introduced at the moment are some standardised statements. Following on from learning from what has been successfully achieved in ASC, some standardised statements, they're being implemented at the moment, and in July they should be fully implemented. So there may be some more improvement in those figures. I don't think that in itself is going to deliver what we need to do. And I think we are now started some work on simplification of the evidence appendix, which members of the board will know is a very big document for many providers and takes a lot of work to produce for our inspectors. And I think it's important we recognise that we may be overambitious in trying to publish too much detail in that, in a format that is actually very difficult to produce. And I think simplification of the evidence appendix may well be the next step to try and drive up this performance. Staff are working very hard on it, though, and have delivered some improvements, but I think we have a way to go on that. Can I just highlight some of the publications that are outlined in your report? First of all, there's just a paragraph just to reassure the board that the 2 reviews, independent reviews of the regulation of Walton Hall are underway, and the board has seen the terms of reference for those. But also I'd like to assure the board that we are not waiting for the outcome of those reviews. We are already undertaking a lot of work to review internally and to change, and we've already implemented some changes in our approach to inspecting these services, and this is having an impact, I think, on our enforcement activity. So we are already learning the lessons from that, but we are looking to the reviews to give us some long-term improvements as well. The Mental Health Code of Practice report, which I mentioned to the board at the last meeting, has now been published. I have to say I am really concerned about the poor compliance with the Mental Health Act Code of Practice, which is reported in this report and has been reported in previous reports, and I see no evidence that compliance with it is improving. And I think that is something we need to take a view on, how we're going to take that forward to improve the implementation of the Mental Health Act going forward. And a report or a series of case studies we put out a couple of weeks ago on innovations in staffing. As the board knows, workforce is one of the biggest challenges facing the health and social care sector at the moment. I am concerned that sometimes regulation is seen as a bar to innovation, and we are very keen to make sure that providers do not see our regulation as a bar to innovation around workforce. We require workforce to be services to be safely staffed, but we do not prescribe the way in the way that is done. And as services develop under the long-term plan, new models of care are developed, it is important that providers are able to innovate in terms of using their multidisciplinary workforce in the most effective and efficient way while maintaining safety. And we want to be partners in that. And we certainly don't want people to be held back in implementing change because of worries about regulation. So this is the start of a process where we're going to be working with providers to encourage them to look at innovative ways of safely staffing their services. So I think a very important initiative.
Thanks, Ted. And then Rosie, please.
Thank you, Peter. So the first thing, following on very nicely from what Ted was saying about innovation and how we're very much working to look at how we don't become a barrier to innovation, just wanted to bring to your attention the NHS England consultation on digital first primary care. As the board knows, we've been working very closely with online providers and have developed a huge amount of learning from the work we've been doing with online providers, and we're very keen to share this learning. So we will be responding to the consultation that's out at the moment. The consultation is running until the 23rd of August. Secondly, I wanted to mention the Defence Medical Services annual report. As the board knows, we're in the second year of a programme with the Defence Medical Services, and the report outlines the findings of the last year's programme, which has shown some improvement in the areas of the Defence Medical Services that we inspect, and that has been very well received by that sector. And finally, I just wanted to mention the annual report on controlled drugs, which has been a really good piece of work, looking at working in partnership with lots of different agencies to look at how we make prescription of controlled drugs safer. There's still work to do, but this partnership working is really moving that in the right direction. So thank you.
Thanks, Rosie. Malta.
Thank you very much, Peter. So a range of updates to the board from me. First of all, in terms of our work with experts by experience, the performance of the current contract is now well and meeting all the KPIs, which is a very good progress. And we're also on track with procuring the new contracts for April 2020. Secondly, I wanted to assure the board that the work we've been doing over the last year in terms of the implementation of the new general data protection regulations that came into force last year in May have gone well for CQC, and that we are assured that we're meeting the requirements of GDPR where we need to, and some further information and detail is provided as part of an annex to the report. Thirdly, recently the Department of Business, Energy and Industrial Strategy published a white paper on regulation for the future and industrial strategy for the UK. I just wanted to draw your attention to this because it raises some really important and interesting questions in the direction of regulation in general, not just for health and social care or quality. In the UK, we're engaging well with that work. Indeed, you will be aware that we have some funding from BEIS for work we're doing on how regulating technologies in the future in health and care. But this sets an important new direction, I think, for the next few years as part of the industrial strategy priorities of the country. And then finally, a number of publications. Declare Your Care campaign, which has now been underway for the last month. In particular, current focus is on how people from a BME background are actually less likely to raise concerns about the quality of care than other groups, and we've been doing some work, particularly in partnership with the Race Equality Foundation, which is very good, to encourage people to come forward and declare their care and share their experiences, including with CQC, but of course in general with all services about that. Then, in terms of upcoming publications, one of them has actually been published yesterday, which is the resource of case studies on how new technologies have been used in health and social care to improve the quality of care, alongside a blog from me about the work that CQC is doing to itself enabling regulation to encourage technology and innovation in social services, in health and social care services. And finally, our annual report on accounts, which we are about to publish. Do we have a date for that, Chris?
Sorry, depending on other matters, hopefully very early next week.
Very early next week. And that's it. Thank you very much.
Ian, do you want to come back?
Thanks, Peter. Just to pay tribute to Malta's team, Ted's team and Chris's team in the way in which the two reports, one on effective staffing and one on technology, have both come out. I think it's worth just underlining to the public who'll be watching this that the purpose of those reports is not to produce a kind of standard report. They are designed to be a very usable resource. It's web-based, it's easy to access, it is talking about things that are already going on, and it's a sort of almost like a how-to guide in terms of how people can improve. And it's part, I think the underlying principle as well is that as a commission, we're keen to encourage innovation and showcase innovation, which is exactly the purpose of this. So we're trying to publish these resources in a different, more accessible way, which we hope will lead to improvements and innovation within the sector more broadly. Thanks, Peter.
Right, so let's open this up for discussion. And can we do it in two parts? Can we start with anything anybody wants to raise in relation to what we've heard so far, and then can we then move on to anything people want to raise under the performance report? But let's start with what's been discussed so far. Is there anything anybody wants to ask or raise? Blimey, right. Let's move swiftly on while we're ahead. So that takes us on to the performance report. John.
I just wanted to say thank you for the new structure of the performance report. I thought it makes the data a lot more accessible and our ability to interpret. I particularly welcome the control charts, which, as Ted says, demonstrates consistent variation around an existing system rather than a shift in the system, and I'm pleased to see that that has produced some. I think the return to rating graphs might need a little bit of attention, but I just wanted to acknowledge the big change and to thank you for it.
So I'm glad I wasn't the only person who didn't quite understand the return to rating graph and what it was telling us. So thanks, John. Right, Robert.
Thank you, Peter. Question about two things which both relate to outcomes. Firstly, in relation to enforcement, we now have, at first blush, a 58% quote success rate struck me as being slightly disappointing, but I'm sure it's small numbers and so on. And the question I had, though, was whether when we take enforcement action and it doesn't work, whatever that may mean in the context, what learning we take from that. It's easier to obviously take learning from things which have gone right, but those where there hasn't been. And a similar question about the whistleblowing aspect, and quite rightly, a lot of whistleblowing information ends up being converted into a safeguarding notification. And I just wonder whether we have, or an inspection brought forward, or whatever. And I just wonder whether we have any way of analysing whether the information we got turned out to be correct. I mean, in other words, a safeguarding alert doesn't necessarily mean turned out was really a safeguarding issue. A lot of the time, it will. And I just wonder whether we follow up things in that way so that we can demonstrate the effectiveness of what people tell us.
Can I just add, because it's in the same sort of line, certainly for our next meeting, I'd welcome a sort of commentary on what are the reasons why we fail to take enforcement action within the prescribed timescale, and are they items that actually, or issues rather, that are within our control, and it's a failure by us for good or bad reason, or are they outside our control? And you just can't tell from the information we've got. And again, it's quite small numbers. The graph looks quite frightening, but actually it's small numbers. But nevertheless, if we aren't taking enforcement action within the timescale which we believe is appropriate, then there is an issue which we need to understand. But I'm quite happy for that to be at the next meeting, unless anybody wants to volunteer an answer. So, coming back to points that have been raised.
I'll have a go at them, and possibly Rebecca can chip in. In terms of the enforcement point, I think we did talk about this briefly at the last meeting, and my intention is to bring back I think your word commentary, I think, is the best way of describing it, because I think enforcement is a pretty complex area, and I think trying to reduce it to a set of numbers and graphs can sometimes be misleading. But I think what we're trying to do is bring back a single report as a commentary piece which tries to unpack some of these things, and then at that point we can decide if there is a set of different numbers we might want to bring back, or whether we want to just revisit this periodically, and we can decide that at the next meeting. To Robert's point, I think the question was, are we tracking through where we get a whistleblowing query? Are we tracking through whether the whistleblowing query was right, in inverted commas, and then what are we doing about it? At the risk of dodging the question, I think it is a similarly complex issue, and I think certainly just as a case study, I think some of the recent whistleblowing around learning disabilities and autism homes on the back of Walton Hall has given us some interesting perspectives in terms of what people tell us versus what we find when we then go forward and inspect. And sometimes people go through a series of iterations where they might tell us a small thing, we might go in and look, some other things may or may not be visible, and then there's another second go at the whistleblowing. So I think whistleblowing is another similarly complex area that perhaps would benefit from again another commentary piece, because I know it's an area of interest from all of us, and I'm certainly of the view that we could be more efficient and effective, and I know Ursula and colleagues are doing some work on exactly how we follow through some of these whistleblowers, how we build relationships with whistleblowers to build confidence, and that we do that within the bounds of law, and we don't get caught up in Regulatory Investigatory Powers Act breaches and all sorts of things. So it feels like a very complex area, but I don't think we currently track through on a one-to-one basis in the way that I think you were alluding to, but I think there's some variant of that we could probably bring forward.
I just want to make clear, it was not that I was expecting there could be a binary answer to yes or no to that, but simply that there is clearly learning to be had from the relationship, the information, and what it actually means.
Good, thanks. Liz.
Sorry, pleased to see in this new format that we've got reference back to the 2018 survey results and our targets going forwards. And it just struck me looking at those results again that there's a bit of a theme coming through in terms of what providers are saying, what the public is saying, what colleagues who work in the CQC are saying, which, and I'm over-generalising, but a lot of trust in the CQC being on the side of people who use services, and similarly from the People Survey been a lot of belief in the values, but perhaps more doubt about the effectiveness of impact. And we've got some targets going forward, and I just wondered how these results are being used in order to help us move towards our targets for seeing some changes in these figures. So, you know, for example, the public are more inclined to feel reassured the service that I use is regulated by the CQC than they are to say that the CQC is driving improvement. You know, and you get that kind of slight difference between trusting that our values are right, we're on the side of people, but what are we actually achieving? And I just wondered whether we're, you know, that focus on effectiveness, how we are prioritising it in order to hopefully see a little shift in those figures going forward.
Quite often at this moment there's a sort of clear indication from one of the executive team who wants to answer the question. There is no indication at the moment, but Chris is going to take a start on it anyway.
Some of the conversations that we have with public and public groups are around linking. I think it sort of speaks to Robert's point about linking their voice and their action to the action we take to driving change and improvement. I think some of the things we've done since this report was out have been around, something have been really important to me about demonstrating how we drive improvements in the sectors that we regulate. So I think we've done more work this year since the 2018 results to demonstrate the impact of our actions, not just at an individual level. Obviously, we publish where we see improvement in services. We publish about 1,400 stories a month on that. Local improvement will reference that. But I think bringing that together in a way that's meaningful for not just for members of the public, but actually for organisations that represent the public. So making sure that they are aware of their contribution to that impact, but also what impact we have. And I think there's more to do in that space. So we talked about the technology report that we've published today, and yesterday, and the work we'll do, I think, going forward around linking our actions and what we see and trying to sort of provide a composite picture of what our actions have led to in particular sectors, in particular areas are important. The area I think to explore as we NHS develop a more regional approach to that is how we can influence that conversation regionally, so we can talk about services across health and care and our influence regionally in each area, and I think that's an area we need to explore in this year going forward.
Mark.
Thank you, Chairman. Building on Liz's question around the charts themselves and the targets and linked back to the survey results, I just have a question about our scale of ambition. So, for instance, if we look at chart 28, where CQC colleagues tell us that technology we use is effective, we have a target of 30%, and yet the survey results show us that in 2018, 8% strongly agreed and 33% agreed. So it seems our target is not very ambitious. There are other examples of that. Chart 31, where colleagues can make an improvement in their area of work. We've got a target of 55%, and we already achieved that in strongly agreed and agreed last year. So is it just a question about our scale of ambition?
Funny enough, that was a point I was going to raise. I don't know if these targets are the right target, and whether what's represented here is the target that actually exists. If it is, then it's not the right target in my view. They're far too low. If only 30% of our staff think that if our target is to get to 30% of our staff thinking our IT is helpful, it's really worrying. So I don't know what's gone wrong here. I was going to ask the same question.
I'm not sure, to be honest. I think we need to take it away and look at it, because that doesn't look right to me. No.
I wonder if we've inverted it. I think there may be an inversion.
Say again, sorry.
I think we wonder if we've inverted so it's in a sense 70%. Not. I think. Let's take it away. But I think that might be the issue.
Certainly, something looks as if it's gone wrong. Seriously, yeah. Thank you, Mark.
Thanks, Chairman. Could I ask another question on chart 42? We talk about people and learning and their uptake of learning and development. When And we have two sort of real outliers there, which are health and safety and values. And I just wondered if somebody from the executive team could explain that sort of seemingly odd outcome.
Yeah, I can do that. Thank you. This is because the CQC values information training and the health and safety training are annually mandatory training modules for all staff, so that data of the 15% and 14% is since April this year, and we're going to get it to over 95% by the end of 2019-20. The other 5 modules you see there are one-off trainings that people need to do once. And so that's cumulative over time. So I think we need to explain that on the slides in future. But so I'm not worried about the 15 and 14% because that's where we want to get to by the end of the year.
Thank you.
Anything else on the performance slides anybody wants to raise? Okay, so let's move on then to the Restraints, Seclusion and Segregation report. We were going to be joined at this stage by Paul Elliott, our Deputy Chief Inspector for Mental Health. Unfortunately, Paul has a significant family illness and is not here today. And I'm really disappointed. I'm really sorry for Paul, obviously, and his family, but I'm also very disappointed because this would have been Paul's last appearance at the board before he retired. And I wanted to have the opportunity publicly to thank Paul for the huge contribution he's made to CQC, to mental health and to the people who use mental health services. And sorry that Paul isn't here for me to say that to him to his face publicly. I will say it to his face privately, and I've said it publicly, but not with Paul here, so that's a shame. However, one of the bonuses of not having Paul here is we get Ursula. So Ursula, you're extremely welcome. You're extremely welcome. Ted, do you want to introduce this?
Could I?
Please.
Thank you. Well, before Ursula speaks, can I just reiterate your tribute to Paul Elliott? It is disappointing he's not here. He's led on this thematic review, and he's led on it very well. And discussing it with him as he's developed it over the last few months, it's very clear that he has, through his diligence and the team supporting him, of course, unearthed really serious issues that the health system is not addressing. I think members of the board would share with me the shock of reading the interim report that Paul wrote. And I know he thinks it's very important this is taken forward. He will be leaving the CQC shortly, but he's really committed to us seeing this through, and I think this is really very important. We do see this process through to make sure that the issues that have been identified in this report are properly addressed going forward. And this report summarises the interim recommendations of the interim report and the steps we're taking to make sure they're implemented. And I'll hand over to Ursula at this stage.
I think the report itself is fairly self-explanatory. I mean, it clearly takes us through the publication of the interim report in May. And again, I think not only to reiterate the findings of the report, but actually that this has been a cumulative identification, particularly through the first phase of our inspection work and the identification by Paul and the mental health team of this as a thematic area of concern, and our work with the Mental Health Act team as well. It was clear that the phase one was only going to be able to be that, and that we did want to make sure that we were looking comprehensively both across adult social care as well as the more traditional hospital settings, recognise this challenge, and that it will comprehensively look at adults and children's residential services and the secure children's homes, which sit in my remit jointly with Ofsted, where again, in the secure children's home, some of the conversations about seclusion and restraint are even more complicated in the context of the security regime, but how we keep a human rights focus around some of those children and young people who are actually more likely to have undiagnosed conditions, perhaps, rather than those that have been identified in terms of care needs. At the bottom of page 2, I think is something really important about thinking about the future clinical model, which is actually it's not just about what's happening in the Tier 4 or the current placement. It's actually usually about an escalation of behaviours and difficulties with managing a number of previous placements, which both results in huge issues in terms of the behaviours that are presented, but also the psychological distress, not only for the person using services, but actually for their whole family and community, that makes both this admission a sense of huge crisis and failure for people, but is also, we think, part of the challenge of enabling people to be discharged. And we hope that our care model, and for the care model work to be successful, it will need to look at all stages of that, because if you only look at the last stage of sticking the finger in the dike, actually you're not really going to address what a range of those underlying issues are, right the way back to early identification, early intervention, and right the way through how the different tiers of services are properly supported. I think the other important thing about this piece of work is that clearly it's working from real and lived examples. It's working strongly with the involving people who've used services and experts by experience, and working with families, carers and staff. I think it's really important in these services to understand what the experiences of staff and what the environments and culture are that enable staff to be able to feel supported, to give of their best in what can be not only physically demanding environments, but actually a huge amount of emotional labour involved in providing some of this care day in and day out. As with all of our work, we're seeking to draw on the strongest evidence and research base that we can, and as you will see page 3, not only are we convening a group of national experts, but we're also looking to convene a group of international experts, since we think there is a lot to learn from other parts of the world. Sadly, these challenges are not unique to England or the United Kingdom, and we think that many of the solutions may be help to be found from looking across the world. Clearly, some of those issues aren't just about what the model of care is, but it's about the role of everybody involved in the system, commissioners, providers, and we think particularly the role of those who advocate, both as organisationally on behalf of some of these client groups and population groups, but also the infrastructure available to advocate at an individual level, both to enable co-production of care, but also to enable people to be able to articulate early where their needs are not being met and where changes might be necessary. There is now, understandably, a connection with the Wharton Hall reviews, and particularly the emphasis on there's what should the care models be, and then there is what is our role as a regulator in not only regulating and monitoring these services, but being part of the change system and the leadership system that we think needs to be in place. And again, we will draw on the work from both of the reviews, but particularly both Glynis Murphy's professional expertise in this area, the networks that she will be able to draw us to. And as Ted has said, we are doing some of the things that we can do immediately, but we will be looking to produce a strong evidence base that we hope will have a wide impact to enable people who use services, their parents and communities, to be able to speak out more clearly for what it is that they need and want, for providers to be able to respond, for commissioners to understand what their role is, and for we as a regulator to be a leader at the centre of both improvement and assurance and reassurance about the safety and effectiveness of these clinical services moving forward.
Great, thank you, Ursula. Any questions or comments? Really, really, really important piece of work, and thanks for stepping in. Oh, sorry, Mark.
Ursula, thanks very much, and as the Chairman said, a very important report. In terms of the meeting in August with the experts, I just really would like to think that an area that they will look at is the development of a workforce plan that ensures that there are opportunities for people to acquire the skills and career paths that attract a workforce into this critical area of work. wonder if you can comment that that is in the spec for that particular meeting.
Yes, I am aware that it absolutely is. Not only because we identified as you've indicated, it's not simply about training and skills. I think it's about the value that society puts on this sort of work, how it is that we recognise it and really recognise and understand and support and what those wraparound support systems are. You know, we understand, we do quite a lot of it in those, if I may call them sexy areas like neonatal intensive care, but actually doing this sort of work is really, really challenging and difficult. So it's where does the workforce come from, what are the training and skills that they need, but what do we need to do to raise the profile of this is real, and we are privileged to meet, and I know, you know, even in the report where they found real challenges, they also found huge numbers of individual members of staff and individual teams really trying their best in incredibly challenging circumstances to do the best that they could, but often unrecognised and poorly supported. Not only within the institution, but I think some of the things that were highlighted were the connections out with specialist services, what the ongoing role is of the psychiatrists and other members of the specialist team, who can sometimes feels a bit as if they sort of abandon people when they, you know, they've been a bit of a challenge in the community and they sort of send them off here. So it's about what that specialist workforce is that wraps around and what that core workforce is, as you say, Mark, and that will be a big chunk of both our national work and, again, drawing from international comparisons.
I'd just like also to pay tribute to this report and also its approach from the basis of the impact on the people who are meant to be the subjects and the beneficiaries of a service which clearly on the basis of this report and whatever else one knows seems unfit for purpose for the problems that people like this actually have. I mean, it seems to be for us at CQC, and I know we will be developing this, the important issue is the extent to which, what our approach is to the registration of places which provide this service. And that's not to blame the efforts made by services that currently exist, but clearly they are not, you don't need to go much further than this without, and you don't need to be a psychiatrist to understand that there's clearly something profoundly wrong about the services that are currently provided. And it is, I'm afraid, it seems to me, attached to the lack of value placed on the welfare of the unfortunate people who suffer from these conditions. And as has been said, if we were talking about neonatal intensive care, or indeed the profound dedication given to some forms of incurable cancer, we would probably be talking in a very different light. So it is about priorities, and it seems to me this has been a neglected area, and I congratulate Paul and his colleagues for shining a harsh light on it.
Thank you. Liz.
Thanks very much. And I think that the focus not only on what happens to the people who are already in such settings, but at least as importantly, what it would take, given the pathways, to stop many more people getting into these settings is actually hugely important. And I'm very pleased that we are using our voice and our evidence base and extending our evidence base with these, looking at the international evidence and so on, to have to help shape some of that debate. Obviously not just us, but and I imagine that, like with the Department of Health and Social Care leading work to consider options on what additional safeguards might be needed and so on, I'm assuming that we are kind of linked into that and contributing. And I suppose that I think the emphasis on thinking about human rights is important. I'm aware, for example, internationally, there was a recent report on how a European report actually on how sort of the promise of independent living hasn't really been realised across Europe, that those great big institutions that got closed have often been replaced by what you might call mini institutions that have replicated some of the problems of the older institutions. But I think there are also some sort of, glimmers of good practice from other countries. So I just wanted to really kind of applaud that. And And I think that some of this might have some far-reaching implications, as I think Robert was perhaps hinting around, future registration and regulations on for us as well as for wider practice and policy.
Ted.
I accept your challenge, Robert and Liz, around registration, and we need to consider our approach to that. But this whole issue cannot be resolved just by regulation alone. That is the point. We need to get the system to step up to this. We've identified it, and we are part of the solution, but we are not the whole solution. And I think there's a much wider system issue about addressing some of the issues that this has just raised, but also how these patients end up in these services, and the level of care they're getting is not appropriate to their needs. And I think it is very clear from the report that this is a much wider issue that could just be addressed by a change of the regulatory approach. We have to consider our role, but we have to work with others.
Sorry, you?
Me. Thank you. Sure. I just wanted to reassure a number of people that particularly the meeting in August is being run in conjunction with the British Institute of Learning Disability. And Paul Elliott and I were with some families yesterday who are families of people whose children have got learning disabilities and are now in most cases adults. And they were telling us the sort of stories that Liz, I think, was just describing, is that people don't suddenly arrive in a closed institution. They had a sort of step up and step down stories. So we want to try and get those voices into the room as well. So whilst we want to draw upon international expertise, we want to work with Build as well, alongside getting families to introduce the sessions to make sure that the voices of people receiving the services and their families, as Ursula pointed out right at the top of the session, are in the room as those conversations take place.
So,
I was just going to add, Peter, that
with a microphone, please.
Is that one of the other important pieces of jigsaw puzzle we have, leading back to Ian's conversation, is the result of the reports, the joint reports we do with Ofsted on SEND and special educational needs, because there's a richness in that material which we already know about to draw into this, because it does, for many of the children and young people who go on to be these adults, identify right from under 5 what this whole journey has been, and we will draw that into the thinking, because we have that richness accessible to us.
So I think there's huge support from the board for the work that you and colleagues are doing, and thank you for that. And I think there's support from everything we've discussed this morning for the process you're going through and the building blocks to producing the next report. Clearly, when that work is done, the board will have a much more in-depth discussion about the learning from that report. So this is not the last word on it by any means, but a really useful update. So thank you, Ursula, for doing that. Thank you to colleagues. Which then moves us on, Robert, to the update from Health Watch England. I don't know if Imelda is...
I'm afraid Imelda presents her apologies and is because she's had to be elsewhere, in fact, at a Health Watch event. So I'm the new Imelda. So
she's let you out alone. This is worrying.
I won't take long. You've got, I hope you would accept, a comprehensive report in front of you about the activities of Health Watch. But if I could just highlight one or two things. Firstly, the work that's been going on in the Health Watch network on the long-term plan. Just to remind you that Health Watch firstly contributed to the formulation of the long-term plan by informing it with a huge number of views as to people's needs and experiences, which had a clear and express influence on the plan. Coming out of that, Health Watch was commissioned by the NHS England to undertake local consultation exercises in relation to local implementation, and that work has been ongoing. So there's one exception, but 151 local health watches have been engaged in that exercise with their local health economy and networks, with a huge amount of activity in a really rather short period of time. So we've given examples in the report of that. but it means that collectively a really very large number of people have been able to have their say locally, and some of it by quite innovative means. I think it's in Somerset, a camper van has been patrolling the outer reaches of rural communities to enable people to come and talk about the issues that concern them, and in other places groups of young people have been got together to do things as well. So there's a huge range of innovation as to how you actually engage people in health issues, which has been hugely encouraging. And I think that it provides a model for going forward as to how the people can contribute to the reformation, if you like, of health and social care services and be really involved in the decision making in a way that hasn't happened before. So I think that's really good work. I'd just like to mention briefly the resource that we now have developed of bringing together, you might be surprised it hasn't happened before, but we have now brought together the reports that are produced by local health watches up and down the country about the issues that concern them into our website. It's ongoing work. I think we've got all the reports from, I think it's 2018 there so far, but within a short period of time we will have those going back much further than that. And I do recommend that if anyone has an issue they are thinking of talking about, making a decision, it's worth trying to search that in order to find whether actually Health Watch has had anything to say about it. Because the one thing you can guarantee about Health Watch's views is they often go and approach communities who are often don't get much of a voice, and they often come back with issues that no one else has really thought of before. In terms of reports we at Health Watch England have produced, I draw your attention to the report that has been recently published, and I think it was mentioned earlier in the meeting actually, about the standard of care and services offered to people with dementia, which does raise some issues around the reviews that people with dementia and their carers get in relation to their needs, and there isn't a statutory obligation for those reviews to be undertaken. And I won't go through the figures, but it does look as though there is a mismatch between the theoretical obligation to undertake those reviews, to identify needs, and them actually taking place. And then finally, we yet again offer you a fairly long report on intelligence that's been coming in the last quarter, which gives you a flavour of sort of things that we at Health Watch and local Health Watches find. And the one I would pick out for this time, which is in one way an old chestnut, but is indicative of the fact that there are problems that never seem to get solved, and that's about patient transport and parking. And I remember back at Mid Staffordshire, rather to my surprise, and of course it was somewhat concerning, that the major complaint that seemed to receive any attention at Mid Staffordshire was about parking. And I rather dismissed that at the time, but actually the reality for patients and their experience of being able to get to places where they're meant to be receiving treatment can be very real indeed. And that's not only in rural communities, but it can exist in more urban communities as well. And it isn't all about parking fees, but I know there are issues in some places around the concessions given to people with disability whose only means of getting to a hospital appointment will be by patient transport. And it is something I think that probably deserves more attention than it gets. And it's and actually, if I could add to what patients experience, it's pretty well known that there are many places where the staff ability to get to work in the middle of the night is pretty challenged as well. So in a time when we're talking about the need to save the climate and so on, we also need to find more imaginative ways of getting patients to places, or dare I say it, the service to the places where patients are, in a more economic way. But that's, if anyone wants to ask any questions, please do, but that is all in the report.
Paul.
Peter, Robert, I first of all to commend you on the report. There's such a wealth of information which is coming through in there. It's the first thing that strikes me in reading it, certainly. And the range of topics and the range of the ability to look across the country in this way is, I think, fantastic. The question I had was partly for yourself and partly, I think, possibly for the executive, which is, how well are we, these aren't aimed just at us, but how well are we actually accessing the information and using the information which is provided in Healthwatch's view? How well is CQC interacting with Healthwatch to use the information effectively? And what more could be done to build this as a route for future intelligence?
Thank you. Well, I think it's an improving picture is the answer to that. I think that there is scope for a better interchange between CQC and Healthwatch, and we are only, after all, the floor away from each other. But I'm constantly having meetings with stakeholders, maybe it might be charities or research foundations and so on, and point out to them that some of what they're looking for may be already within the information that Healthwatch has. Not everyone is happy with the idea that Healthwatch is a subcommittee of the Care Quality Commission, but given that it is, it seems to me that we should be, and I think hope increasingly are, regarded as a resource of the CQC for providing more intelligence. But so I would say this is an ongoing relationship, and I think there are better ways we could discuss about using it. The other point is that often our information does get used without us actually being credited for it, and I'm quite keen on, and I do in various quarters ask that we be mentioned if our information is actually being used, because the more that happens, the more people will use it.
Rosie.
I was just going to add to that, because some of the work we're doing across the directorates at the moment is to encourage our teams locally to get together to look at risk in a local area. And some of the teams have started to reach out to their local Healthwatch partners to have those conversations and build those relationships. And that's something I think we need to encourage more of to develop. So,
oh, Chris, go on then.
I was just saying, on a very practical, I think I agree with you, Robert, about there's more we can do. But I think we've, certainly for State of Care and some of the other main publications, there's been a really good dialogue around using the wealth of information that sits in there to support some of the messages. And one of the things we'll talk about that a bit later, we're sitting down early to work out what our sort of plan of messages are over a period of time and how we have a collective voice together. I think even if they're at different times where we use each other's information is important, and that's certainly an area we've been exploring over the last sort of 5 to 6 months.
So, Robert, I'm conscious that we frequently thank Healthwatch England and congratulate Healthwatch England on reports and the information that comes to the board and so on. But I don't think we probably have thanked the local Healthwatches enough. So I'd be very grateful if you would find a mechanism to communicate back to the local Healthwatches that this board really values the work that they're doing.
Well, thank you for that. You've just missed my last chairman's letter, which went out yesterday, I think, so I'll put it in the next one.
Thank you. Right, so we had a meeting of the Regulatory Governance Committee yesterday evening, and as is our normal method of proceeding, we asked the Chair to just give a quick oral update. Liz, congratulations on taking over the chair of the RGC, and over to you, please.
Thank you. Yes, we talked about two significant issues. The first was primary care at scale. So primary care is changing. Firstly, the NHS long-term plan signalled universal coverage of primary care networks. So primary care really coming together for populations of 30 to 50,000 people with new different workforces, things like social prescribing, link workers and so on. So that's one development. And another development is sort of primary care at scale where practices are coming together in different kind of configurations, different models, some as formal entities or in different ways. And so we had a discussion about what that means for CQC. It was kind of fact-finding, and the team has been doing some engagement with some of those new configurations, and I think concluding that that engagement in itself is really, really important, that we need to understand how those developments are going to influence the changing shape of primary care for patients. This was a very kind of early stage discussion, so it was more kind of understanding the fact-finding that's been going on. I think this is something that we'll need to come back to the board in the fullness of time when we've got some sort of clearer proposals of whether there's any adjustments that we want to make to any of our methodologies or whatever in the light of those changes. But clearly we need to be kind of ahead of that curve of change. The second item, as the board knows, we will be developing a new strategic plan kicking off from 2021, but the early thinking and early work is already in train. So we had a discussion yesterday about horizon scanning. So what might the future look like? And this is a difficult judgment to make. The team has been devising some sort of methods to think about the alternative kind of scenarios that could occur under a number of thematic areas, you know, whether that's changes in policy or changes in social trends or whatever. And I think some of the important things that came up in terms of those methods were that we're not going to duplicate a lot of organisations look at the future. You know, government does, organisations like the Health Foundation, the King's Fund and so on. We're not going to duplicate, we're going to learn from them. And we will focus particularly on kind of the future of regulation and the implications for us. So in the Regulatory Governance Committee, we looked at the proposed approach to thinking about all this. You know, that it was really very early stages of design. And I think that the view of the committee was that we thought that the proposed approach was strong. It was very useful to have alternative scenarios. We shouldn't be thinking we know exactly the future is going to go this way. We like the identification of the themes and so on. And the areas where we gave some advice back to the team were particularly around the use of several scenarios under each theme to make sure we don't miss key issues, and particularly engagement all the way through this. So both internal engagement but also external engagement, so that we get as rich a discussion as possible. We don't miss things, and that we involve people early on who are going to give us some kind of different perspectives, help us think about things we might not have thought of and so on. So that was it on that. And the only other small thing is we're going to make a little adjustment to our terms of reference for the Regulatory Governance Committee, so that will come back to the board, and that's really just to make sure we're keeping up with not only focusing on inspection but the whole of regulation, make that really clear and as relevant, looking at future as well as future things like future of our regulatory approaches as well as what we're doing now.
Thanks, Liz. It was an excellent meeting, and thank you very much for that report. Is there any other business that the board wishes to raise? No? Good. Excellent. So that's the end of the meeting. I have been notified of 2 questions from the public. I see both the members who raised questions sitting there. So, Robin, you were first in this time. Robin Pike.
Thank you, Chairman. Robin Pike, Healthwatch Hertfordshire, a patient representative. I wondered how the Commission might more effectively communicate to the public the nature of the work that it does. This is in the context of a number of negative television programmes in relation to CQC, and also some media coverage as well, newspapers like the Times. In the early days of the Commission, I asked a question whether it would be possible to commission some television programmes that show the excellent work which inspectors do. There are a lot of documentaries which deal with hospitals and deal with GP surgeries, and whether it might be possible to put something out into the media which gives this flavour of positivity about the good work that CQC does. And perhaps in relation to item 5 on the agenda today, in segregation and seclusion, I could mention that there is currently a production by Sir Matthew Bourne of Romeo and Juliet, which is set in a secure psychiatric unit in which there is regular sexual and physical abuse of the patients. And this production resonates with the audience, and it could perhaps be borne in mind that there are a range of ways in which issues are brought to public attention.
Robin, thank you. And what you've just said almost touches occasionally on the question that you submitted in advance, which is really good. So thank you for that. But thank you for what you said. Chris, over to you.
First of all, thank you very much for the question. It's an important question. If I do this, the second part first, and then the first part second, if that's okay. So we are. I am in contact with two organisations. One represents BBC, one of which represents an independent television network that works mainly for Channel 4, around whether or not it would be possible to do that. There are quite a few, because we are working in others' premises, there are quite a few other hurdles, if you like, to making that work. But we've been exploring with the BBC for probably now getting on for a year, and at the point where it becomes tenable and also has to pass the commissioning test, i.e. commissioners have to be interested enough in it to run it, I would certainly bring it to the board for consideration. One of the things you may not realise is that we also infiltrate popular programmes, so both in EastEnders, in Casualty and other areas, we have given evidence and sort of supported as plot lines and storylines in the past in the world of what an inspector does, and we'll continue to do that because it is an important vehicle for communicating what we do. If I just quickly talk about the 4 areas of the what we're trying to do around the strategy, if that helps, come back to the sort of second part of your question. Firstly, something I touched on with Robert is how we strengthen our collective voice around where we want to influence changes to health and care policy or practice. What we've been doing for a number of years is that we've had a partnership with Healthwatch in particular, but also with a number of other charities who represent people who use services in different areas, and we come together regularly to talk about where we want to try and raise the voice or raise a concern or try to change a policy issue. So we have a monthly dialogue with all of those groups, and we collectively plot out what we intend to talk about over a time period. We also use the same groups and the same networks to bring together our information around share your experience. So as well as going onto the website, if you go to one of those organisations, all the national organisations that have a contact centre, they have people that have been trained by us to use the share your experience forms and the new improved share your experience forms that are coming out to help us improve our sort of insight into how services are working. Both of those are important because they help. What I'm aware of as a regulator is that people won't necessarily use the regulator as a first point of contact. They may use other organisations, Healthwatch being a very good example, but other organisations that represent particular conditions. And it's important that wherever they go, we are. So that's the rationale for the first one. The second has already been touched on today, but we have our own resources to raise awareness. So the current campaign is around BAME groups of staff, but we have other campaigns where we know we are underrepresented in terms of the voice of people who use services. So we've been particularly targeting those groups. We ran a campaign on maternity recently where we got a tenfold spike in a number of people offering share your experience comments on the back of that survey. And colleagues mentioned earlier, Rosie in particular mentioned the role of the inspection teams and how they play a very important role in engaging locally with Healthwatch. I think this is an area where we've we've needed to and have got better. And I think as we develop a more teams based around a region, based around an area, I think it's important that we can reach out to, in particular, Health Watch and other organisations as well. So we've got a full sense of how their local area is performing. If we think ahead to State of Care this year, one of the issues is that we talk about things as a national service, but actually the variation in those services and how services operate in different areas actually is crucial in determining where poor care might be. So we want to make sure we can talk about that more effectively. In terms of sharing information with the public, so obviously we share information through those networks, but we've got an important role ourselves on the website. We know we want to and need to make some changes to the website. One of the things for me about the way the website operates currently is that it only shows a picture of, or majority shows a picture of our inspection activity. And that's one part, but I think is a much richer, if you look at what Robert's just given us there as a snapshot, and we've got the same with Share Experience, there's a much richer picture of how organisations are performing. One of my ambitions when we have the resources to change the new into the new website is that it becomes not just a vehicle for inspection reports, but becomes in a sense a real-time picture, or as near real-time as we can get, picture of how people are experiencing those services and how the information that supports our understanding of those services is relayed well to the public so they can make choice. The last area, and it's an important area as well for us, is how we work with people who use services to improve how we operate, and also how we, if we're changing our own thinking about services. Now, I'll call to mind the recent work we've done on restraint and seclusion. So we've had a lot of dialogue with service users and their families around that report, around the interim report, its messages, and also begin to think a bit about how we might change what we do. And I think it's important that whenever we look to how organisations change to improve, they engage their colleagues, their staff, and the people using their services. And I think it's important that we do the same in our work. And the role of experts by experience in that, the role of our own sort of reach out groups to national charities, and the role of individuals that we bring into that are very important. So I don't think this is I'm sort of restless about this. I think this is something that we still need to improve on, but those are the areas where I want to see the changes and where we've begun to see the changes in how we operate. I don't think that helps or gives an answer to your question.
Thank you, Chris, and thanks, Robin, very much indeed. David, we had 2 questions from you, which we'll try and take quickly because we're running out of time, and then that will be that. So, David.
David Hogarth. I'm the coordinator of Neighbour Care St John's Wood and Maida Vale. My first question is about technology, and in particular about the specialist technology which enables people who, like myself, are not very happy with mobile phones and Skype and so forth, to still communicate with their families who may be far away from them, and with other people as well. And you may not be aware that over the last 3 months there have been 3 presentations at CQC from providers of this kind of technology, at which I was privileged to be present, and Peter was also present. So my first question is really to ask Peter what he thought, what thoughts he had as a result of this. I don't know whether you want me to go on to the other question now, or you want to answer.
I'll ask your second question and then we'll answer.
Right.
Thank you.
And my second one relates back to the executive report, and particularly Ted Baker's section where he mentioned Walton Hall, and that there was going to be a briefing for inspectors about warning signs, things to look out for, so as perhaps to avoid this kind of problem in the future. My question really is seems to me that such a briefing would be highly relevant, not just in that particular inspectorate, but also in particularly the social care one. And is it going to be extended to them? Are they going to have access to it? Are also the public going to have access to it? I'd be very interested certainly to see what you thought you needed to look out for. So those are my 2 questions.
Thanks, David. So I'll take the first one since it was addressed to me. So we know that isolation is a major problem for people, and it affects their physical and mental health. So anything which helps people keep in touch with family, friends, and carers and all kinds of other people is really welcome. So I've been fascinated by the technology that is being developed. I've actually had a lot more presentations over the last couple of years than the three you and I have had recently. So what I'm about to say applies to the generality rather than those three in particular. They all have a part to play. They all have quite different functionality. I think some are much more effective than others, in my opinion. There are two drawbacks, though, which we need to be clear about. One is that parts of the country where the isolation is at its greatest suffers from a lack of broadband and a lack of mobile phone signal. So the technology simply won't work. And I was at an event organised a couple of weeks ago by Somerset Community Foundation, which was on the impact of isolation in rural Somerset, and in particular in places like Exmoor, where apart from the fact there is no public transport and there are very few jobs, there is no broadband signal and no mobile signal. So there are limitations to what technology can do. We need to be aware of that. And the other is that I think quite a lot of the types of service that you're talking about are quite expensive. I mean, they're very affordable for people who've got a little bit of money, but they aren't affordable for everybody. So I think you just need to be very clear that they have limitations. So I don't think they completely, in my mind anyway, replace the need for the sort of work that you personally do. I was at an event again in Somerset the other day with Age UK Somerset, where looking at their befriending scheme, and I think those sorts of things are also going to be part of what is needed to address isolation. So long-winded answer to your question. I think what we've seen are good. There will be more products. They will change over time, but they're only part of a solution. They're not a complete solution in themselves. So that was that. Kate, do you want to answer the second question, please?
So in relation to the briefing for inspectors about what to look out for when they go into closed institutions or establishments, we piloted that model in adult social care, slightly tweaked it, and it has now been shared with all managers across England in adult social care, with a view to them having a conversation with their team over the next week. And we've also in recent days used it to plan an inspection of a service that we had some concerns about. So it has been actioned, and that is being taken forward. Your question about whether a version of it could be made available to the public. So we've been having some conversations with Healthwatch about what that might look like if we were able to share a part of it or a view of it with Healthwatch colleagues. As to whether that would also be suitable for the public is something I think maybe we could take away. So if that could be an action for maybe Chris, myself and Melda from Healthwatch to look at how that could be adapted and if it's appropriate, and then we could just update the board next time if that's okay.
Lovely. Thank you very much indeed. Thanks, David.
Thank you very much.
That is the end of the meeting. Board, we start again at 1 o'clock. Thank you.